So welcome everybody. My PhD topic is about the investigation of pathomechanisms of heart failure and the new methods for its treatment with and without drugs. My name is Richárd Masszi. I came from Városmajor Heart and Vascular Center. I'm doing my residency and my PhD. My vision is to discover every single detail that can influence an outcome of a disease, and my mission is to find more personalized treatments for heart failure patients. I have two ongoing projects here at TMP. The first one is about the predictive value of scar burden assessed by cardiac MRI on sudden cardiac death in cardiac resynchronization patients with the methodology of systematic review and meta-analysis. And I have a second project, which is about the diuretic effects of novel drugs compared to conventional diuretics in acute heart failure. So, about my first project. The problem is that the 5-year mortality rate of heart failure with reduced ejection fraction can reach 50%, out of which 10 to 20% die suddenly. What we already know is that scar burden is believed to be a major cause of sudden cardiac death, and cardiac MRI is the most accurate diagnostic tool for assessing scar burden. ICD is the gold standard therapy for treating sudden cardiac death events. What it would be important is that choosing the optimal device out of ICD, CRTP, and CRTD would save more lives. But we also miss that there's no clear evidence in the guidelines regarding the optimal device choice. Our clinical question is that what is the association between the degree of scar burden assessed by cardiac MRI in regarding sudden cardiac death in CRT patients? Our patient population is heart failure patients undergoing CRT, while our prognostic factor is scar burden assessed by cardiac MRI. We have one outcome of sudden cardiac death events. We hypothesize that the higher the scar burden, the more effective is CRTD in reducing sudden cardiac death events. Our clinical implication could be that optimal device choice would decrease mortality and morbidity and also lower the costs and the complication rates. Here you can see that we conducted a systematic searching for different databases back in November, and out of the articles we selected, we have found 16 eligible articles. We have one outcome, that is sudden cardiac death events. We measured by odds ratio and hazard ratios, these outcomes. And for our first figure, we were analyzing the sudden cardiac death events based on scar burden dichotomization for a short and long-term follow-up model. Our measure of effects was odds ratio, and we found that in the scar-positive patient population, there were 6.5 times higher risk of getting sudden cardiac death events compared to the scar-negative patient population. We found mild to high heterogeneity with the outlier articles of Acosta, Leiva, and Sanchez-Somont. For clinical implication, we would say that it's not only statistically significant, but a clinically significant result, because in the scar-negative patient population, there were a very low incidence of sudden cardiac death events. So in these patients, the defibrillator function wouldn't really help these patients. Because as you already know, the defibrillator function of these devices can abort sudden cardiac death events. We also had a univariate risk model as a hazard ratio for measure of effects. We found out of the articles that there were 2 times higher risks for getting sudden cardiac death events in the scar burden positive group compared to scar burden negative group, with the outlier data of Sanchez-Somont and Leiva's article. We also had a multivariate risk model for 4 articles, which also showed a mathematically and clinically significant result. And we had a competing risk model, which has the highest evidence level and gives us the best estimate for this cohort. And we found out that there were 1.5 times higher risk of getting sudden cardiac death events in the scar burden positive group compared to the scar burden negative, which clinically clearly significant result, although mathematically we found only a trend toward. We also had a subgroup analysis for CRT-only patient population compared to CRT plus ICD. What we have found, as you can see, that the CRT-only patients hadn't have a significant difference between the scar burden positive and scar burden negative patients, and the overall incidence of sudden cardiac death events were also lower compared to ICD and CRT group together. What could be the reason behind that is that CRT, due to the reverse remodeling, the sudden cardiac death events cannot develop that so frequently like patients with ICD on its own. Here you can see my baseline clinical characteristics table with altogether 3,000 patients. And what I would like to emphasize that our meta-analysis is the first meta focusing on CRT patients, and it has a large number of patients, while as for a limitation, it wasn't only CRT patients. And our initial aim was to find an optimal cutoff value that we haven't found, and we didn't had enough data for comparing CRTP only and CRTD patient population. As for a conclusion, I would like to say that high scar burden is associated with 2 to 6 times higher sudden cardiac death events, and the CRT only group scar burden was much lower. In those patients with no scar, the number of sudden cardiac death events was negligible. As for research practice, I would say that randomized controlled trials are definitely needed, as all these articles were observational studies. And for clinical implication, you could say that scar burden assessment helped detecting ICD candidates, and a uniform assessment method is definitely needed. Yes, and here you can see my project status. I also have a second project with the diuretic effects of novel drugs compared to conventional ones in acute heart failure patients, but I would like to tell you the details in the next progress report. Thank you very much for your attention.
Richie, in the framework slide in your presentation, you mentioned that a possible implication in the clinic could be lowering of the morbidity along with the mortality. But of course, since I am familiar with your work, I know the reason why we don't have a meta-analysis about the morbidity, because there is very limited evidence. But my question for you is, what kind of morbidities would you think of as feasible or important to be analyzed or observed in a randomized controlled trial about this topic?
Thank you very much, Anna, for your question. You know, as we are talking about heart failure patients, we could focus on the New York Heart Association score, but it's not, as we will see, it's not the very best outcome that we could analyze in a cohort study or in a randomized control study, but the symptoms of heart failure patients and for example, the 6 minutes walking test that really could imply the state of such kind of patients, that how is possible to have a normal life for these patients, how do they get fatigue in time. So these would be that kind of morbidity outcomes that we could analyze on. But there is plenty of others.
Do you have any data that what kind of rhythm disturbance cause sudden cardiac death, and is there any difference between scar burden positive and negative group?
Thank you very much for this very good question. In heart failure patients, the development of ventricular tachycardias and ventricular fibrillation is more frequent than in the non-heart failure patient population. Regarding the sudden cardiac death events, these are the shockable rhythms through we can abort the sudden cardiac death events. So mainly in these articles, these were the arrhythmias that were reported. Yeah, and your second question?
Is there any difference between scar burden positive and negative group?
In the scar burden positive and the scar burden negative? In the scar burden positive group, there were mostly these life-threatening ventricular arrhythmias that I was referring to. In the scar burden negative patient population, there could be pulseless electric activity and like that. So in the incidence of these arrhythmias were lower in this patient population.
If no other question, I may have one question too. Could you make difference between scar size, and scar pattern? So if the scar is in one big focus or a scatty pattern everywhere, a small part of scar, is there any difference in the arrhythmia or in the outcomes? It's a very difficult question, I know. I'm just curious.
Yeah, that's also a very good question, and thank you for this question. It's very important when we looking at the non-ischemic etiology and the ischemic etiology. Because in an ischemic etiology, for example, if someone already developed an acute myocardial infarction, that the scar size would be more localized, it would be bigger, and we wouldn't even say that in those spots in the middle of the necrosis, this is already died myocytes. So this is not the part when these life-threatening arrhythmias will develop. But in the border zone of the necrotic myocytes and still well-functioning myocytes, this would be the region where these develops. So we would say that there are some channels and also called border zone mass where these life-threatening arrhythmias rather likely to be developed. And in the non-ischemic etiology, these spots are much more difficult to found, and it's more scattered through the myocardium.